Bueno, buenas tardes, noches a todos.
Good evening, good afternoon, everybody. I hope you've had a very fruitful day. We are going to start this activity, a symposium sponsored by Siemens about advances in the angioplasty of coronary interventions through images and the robotic automation for precise treatment. I'll have with me the panels Aníbal, Damonte, José, Álvarez, Gabriel, Maluenda, Alejandro, Fernández, Juan, Mieres, Darío Echeverri, and Pedro, Lemos. Today's speaker is Taishi Hirai, an interventionist cardiologist from Columbia University in Missouri. He is outstanding because he graduated in Nagoya, Japan. That's where he studied in the School of Medicine. Then he went to the US, where he lives since 2008. So for 15 years, just about. And he trained himself in St. Luke's Hospital in Kansas City. And now he is based in Colombia. Dr. Taishi is going to present 2 cases. And from then on, he's going to tell us the benefit of technology in these type of procedures. He does mostly complex angioplasties and chronic complete obstructions. That is going to be exactly what he's going to show in his presentation. Dr. Taishi, the floor is yours.
Well, thank you very much for the introduction, Dr. Londero. And today I would like to show 2 cases. I'm Taishi Hirai, interventional cardiologist from University of Missouri. And the first case will be regards to the use of CorPath GRX system. And the second case is to highlight the use of Artis Icono system, which is the new system from Siemens. So I will play the video here.
So the first case is a 70-year-old gentleman, past medical history of hypertension, hyperlipidemia, and chronic kidney disease, who presented with acute shortness of breath and end stemming. EKG with ischemic changes anterolaterally, and echocardiogram showed ejection fraction of 30% with apical anterior akinesis. This was his baseline coronary angiography, and you can see the left main is intact, but there is significant disease of the LAD. And also there's a disease from the proximal circumflex artery to the OM branch. This is a caudal view. And in the cranial views, you can see the LAD lesion a little better. There is a tandem lesion, 70%, followed by a 90% lesion. The right coronary artery was totally occluded in the distal RCA, and this is the RAO shot. Mid RCA also has about 70% disease. And so based on this finding and the findings from the echocardiogram, we decided to go after the LAD first. So we have the EBU4 guide seated in the left main, and we started the procedure using the robot. So the first guide wire was our workhorse Minamo guide wire, and our bedside operator usually makes the bend, but this was a little too much bend for LAD, and so we were able to advance through the proximal portion, but could not advance the mid portion. But you can see the spin motion here with the Minamo guide wire. We changed the bend and we used the cyan blue guide wire, and using the R, which is a rotate on retract feature of the robot, we were able to wire the mid LAD lesion. We advanced the balloon for pre-dilation. Initially, the balloon did not cross the mid-segment, so we used the turbo button that we have in the robot, and with the turbo speed, we were able to advance the balloon distally. And you can see the pre-dilation here. The IVUS did not cross, but we were able to measure the proximal vessel size. And we performed further dilation with a 2.5 millimeter NC balloon. And here we decided to advance the guide liner for better support. And we delivered the drug-eluting stent 3.0 by 28 millimeter into the mid-LAD. Now the IVUS was able to cross and we were able to see the well-opposed stent. And we were putting the second stent, and here we can see that using the clear stent live feature, we can overlap the stent very well with only 1 or 2 stent strut overlap. Post-dilation was performed with the 3.5 NC balloon up to 20 atmosphere, and again using the clear stent live feature. So this is the final result of the LAD, and we decided to go after the circumflex artery. So here, keeping the cyan blue guide wire in the LAD, we used the Minamo guide wire that we used, and the bend was perfect for the left circumflex artery, so we were able to wire this robotically. And then here's a pre-dilation. Again, IVUS is performed. This time, the lesion length was measured by the IVUS pullback using the constant speed feature, and this is the stent going up. Post-dilation with 3.5 NC balloon up to 20 atmosphere using a clear stent live feature. And these were the final results of the LAD and the left circumflex artery. You can see the collaterals going into the RCA territory. You can see the PL branch is a fairly large branch. Initially, our plan was to stage the RCA as an outpatient, but offline analysis showed that the RCA could be subacute, and therefore we brought him back for a staged PCI to the RCA the following day. So here we're using a 6 French AL guide catheter, and we're using the cyan blue guide wire. And we're wiring this again robotically using the spinning motion. And then a ROR motion. After confirming the position at the proximal cap, the guide wire did not advance with itself, and therefore we actually advanced the balloon for better support robotically as well. And here we're using the new spinning motion. And then we also use the constant speed. And in this case, the wiggle technique seems to make a little more progress. And after switching to ROR technique, we were able to wire through the lesion. After the lesion crossing, we actually did the pre-dilation with the balloon. And here's the technique where you can seat the guide robotically. So with the balloon up, I'm pulling the balloon back with a joystick, and that will automatically seat the guide into the vessel. So despite the good guide position, the balloon did not advance easily. So we used a technique called the doddering technique, and this advanced the balloon nicely. So after this, we did a further pre-dilation. And IVUS examination to decide the size. The guide wire was pulled by the assisting operator during the exchange, but we were able to successfully recover that robotically as well. So this is our typical setting for when we're doing the robotic PCI. You can see this is a cockpit in the control room. You have the same screen that you see in front of you in the cath lab. And you can move the device with these three joysticks. So this is for the balloon, this is for the guide wire, and also for the guide catheter. Today, I would like to share a complex case that highlights the use of Artis Icono system. This is a 76-year-old female with history of hypertension and coronary artery disease status post-bypass in 1990s, diabetes, peripheral vascular disease, chronic kidney disease, stage 5. Her baseline creatinine is about 4.5 and eGFR was 10. She presented to our hospital with dizziness and developed typical angina and diagnosed with non-STEMI. She was initially hesitant for going for a coronary angiography given her creatinine and the risk of dialysis, but the angina did not resolve with initial medical therapy and we could not control even with a nitroglycerin drip. Troponin continued to rise and therefore she underwent coronary angiography. This is her baseline angiogram, and you can see there is a severely calcified RCA with a proximal 80 to 90% disease, and the distal PL branch appears to be occluded. The vein graft that used to supply the RCA was totally occluded. This is a left system, and you can see the LAD is a chronic total occlusion at the proximal portion. Diagonal branch has severe disease, and then osteo left circumflex as well as the mid left circumflex has severely calcified disease as well. This is another view of the left system. Here's a picture of the lima. Lima was widely patent, but we realized that it was actually grafted into the diagonal branch. LAD fills very faintly, likely from the left-to-left collateral or the retrofilling from the diagonal branch. You can also see collaterals to the right system via the septal branches, and you can see the PL branch is a fairly large vessel. So these were her findings, and she has a distal left main to osteo left circumflex with 90% disease. She has a LAD CTO after the diagonal takeoff, the first diagonal with a diffuse disease, mid left circumflex with 90% disease, osteo RCA with 80% disease, and distal PL branch with a total occlusion. We couldn't tell if this was chronic or subacute. The graft lima touches down to the diagonal with a faint left-to-left collaterals to the LAD, and the vein grafts were occluded, and the EDP was 18 millimeters of mercury. She underwent temporary dialysis and fluid removal in preparation for her staged PCI. So our plan was to perform PCI to the distal RCA and PL branch, the PCI to the mid left circumflex, and provisional stenting into the left main osteo left circumflex, but keep the do a kissing balloon inflation to open the stent struts in case she needs CTO PCI to the LAD in the future. So we started from the right here, and you have a JR guide, and using a Corsair 135 centimeter, we have a workhorse wire, and the total occlusion was able to be crossed with the Pilot 200 guide wire. After exchanging back into the workhorse wire, we advanced the balloon with the guide liner support, and we were able to perform a balloon angioplasty to the PL branch. Because of the proximal lesion, when we advanced the guide liner, she became very ischemic, and so we did this part very quickly. By IVUS examination, we show circumferential calcium, and therefore we decided to treat the proximal RCA first. And after further dilation with 2.5 millimeter cutting balloon, we performed a PCI with a 3.0 by 20 millimeter drug-eluting stent, which was post-dilated with a 3.5 NC balloon and an osteoflash balloon. After this, we performed further angioplasty of the PL branch with a 2.5 millimeter balloon, and we left the RCA here with a good flow to the PL branch as well. Next, we went to the left system, and this is a pre-dilation of the left main to the osteo left circumflex artery. We did the IVUS examination, and because it was severely calcified as well, we did the pre-dilation using the cutting balloon. And we performed PCI with a 3.0 by 24 millimeter drug-eluting stent distally. and another one proximally from the left main into the circumflex artery. We performed POT with a 4O NC balloon, and after recross, we actually wired into the diagonal branch, and with this wire, we performed a balloon angioplasty of the diagonal branch and performed a kissing balloon to open the stent strut. So the final pot here, we did it with a 4O NC balloon using the Clear Stent Live feature. And you can see the good quality images even in the spider shot. And you can see that I can land the balloon right at the ostium of the stent. So this was the final angiogram. And this was 100 cc of contrast with 1.8 gray radiation. So her hospital course, her chest pain actually resolved after the procedure. She had a good urine output and did not require further dialysis, and she was discharged the following day with a close follow-up. So here I presented the case that highlights the use of Artis Icono system with a clear visualization, even in the steep angle such as spider shot.
So the first case summarizes the use of a CorPath system in a multi-vessel PCI. The LAD was actually more calcified than we suspected angiographically. So the new automated wiring system that we have in the CorPath GRX system was very helpful in crossing the lesion. We also used some of the advanced techniques for calcified lesions, such as using the turbo button, dottering technique, and robotic guide catheter seating, and the use of guide extension catheters. The second case was a complex PCI case where I think the Artis Icono system was integral to the procedure success. Because of the left main lesion, we had to use the spider view, but the small C-arm allowed us to take a steeper angle with a very good image quality. And the clear stent feature allowed me to precisely place the stent and do the post-dilation precisely. So overall, at University of Missouri, we started using this system last December, and we started using the CorPath GRX system starting from January. We have performed about 35 cases robotically, and I think our team continues to grow. I did have a background in doing the robotic cases during my CTO chip training at St. Luke's Hospital in Kansas City back in 2018. So I did have some experience to start with, but I wanted to share if there was any, share our experience if there was any questions from the panel.
Bueno, muchas gracias, doctor Taishi, muy ilustrativos sus casos. Yo voy a pedir que quien quiera hacer una pregunta, tratemos de hacer preguntas, no aportes. Levante la mano, no veo el sistema para que levanten la mano virtualmente, digamos, así que van a tener que levantar la mano los que quieran hablar. Yo, si quieren, puedo iniciar con una pregunta para ir avanzando. Doctor Taishi, yo he visto que usted usó Clear Stent en los dos casos, o sea, un sistema de Enhancement Stent Contrast para ver la posición del stent y la expansión del stent. ¿En qué medida usted cree que el Clear Stent o sistemas similares pueden reemplazar el IBUS para evaluar el resultado de la angioplastía con stent?
Would you be able to translate to English?
Yes. Do you think that Clear Stent can replace the IBUS in the evaluation of the result of the PTCA?
I think the Clear Stent Live feature is very useful in terms of deciding where to post-dilate when you're putting in the NC balloon inside the stent that you just placed. You can tell the expansion really well. But in terms of whether you're going to see if there's good opposition with the stent, I think IVUS is probably better. So I don't think it'll replace it completely, but it's definitely a good feature when you want to know exactly where you're going to dilate.
¿Tenemos alguna pregunta de los? Sí, Aníbal, vamos, como dice Mangione, por orden alfabético. A, Aníbal.
Okay.
Adelante.
Okay. Thank you, Dr. Taishi, for sharing with us these two very provocative cases. First question is regarding first case and robotic PCI. How do you select during the learning phase of your experience these first 35 cases? Because actually the case you share with us is not a simple case. It's 3-vessel PCI with a possible CTO of the right coronary artery. And how do you identify the feedback of better support? Well, tell us something about this, your initial experience and your experience right now. Thank you.
Thank you very much for the question. Definitely there's a learning curve because the primary operator is sitting in the cockpit, but you have the secondary operator doing the exchange for you. So it's kind of like a team play when you do the robotic case. So in our lab, we have a 2 robotic super user. They're very good at assisting cases, but they haven't had experience with a robot yet. So when I started the case, I started by selecting some of the easier cases. The easier cases are if you use only 1 wire and if you have a good guide support. It becomes harder if you have to use more than 2 guide wires and if you have less difficult anatomy in terms of the guide seating. And so I gradually did that for the first 5 to 6 cases. This is actually our 7th case, but for first 5 or 6 cases, I only selected cases that were kind of simple and we know that we were going to do it right. And then we gradually increased to more complex cases such as this one, total occlusion, calcified cases. Now we're doing it for cases with a CTO. After we cross, we can still connect the robot and complete it with the CTO. After a atherectomy, you can complete with a robot. We've done our STEMI case too. And so we're kind of gradually improving the complexity. What was the second question again?
No, creo que no había una segunda pregunta. It's okay. Yo les voy a contar que hace más o menos 20 años hicimos una experiencia en el desarrollo de los sistemas robóticos para manejo de las guías. Y esa experiencia consistía en introducir el catéter en la vena femoral, llevarlo hasta la aurícula derecha y hacerle doblar la punta. Eso era todo lo que hacía el robot. Pero bueno, hace 20 años o 25 años de esto, ahí iniciamos la experiencia y hoy podemos completar una angioplastía solo trabajando con el robot. Do you understand, Dr. Taishi?
I'm sorry, would you mind repeating in English?
Yes, I was telling there that I was working at the very beginning of robotic control of the wires and so on. And our first experience was to advance in the vein system a catheter to the right atrium to make the cure there and retire. That's all. This was 20 years ago. And for me, it's really incredible how it progressed. And now the robotic can, with the robot, you can do CTO and complex angioplasty. Yes.
Yeah, so I think the newer generation of this robotic system compared to the first generation is that you can actually manipulate the guide. And you have a joystick for the guide catheter. And that has made it a significant difference because now you can seat and unseat the guide during complex case. And so that definitely makes the procedure more efficient.
Gabriel, tú tenías una segunda pregunta.
Sí, la hago en inglés, supongo. Dr. Hirai, very interesting and challenging cases. So my question is about how do you approach the CTO PCIs? Because I saw in the two cases, you were not doing collateral injection, meaning contralateral injection. So how is it different the way that you approach with the robot, that you are able to do this without the guidance of the contralateral injection?
Yes, so the main limitation of the current robotic system is that you won't be able to advance the over-the-wire system. And so when you do the CTO crossing, in general, you have to cross it manually. And so it's going to be just as, you do the CTO with a dual injection, and then you confirm the guide wire is in the right position. And then there you can exchange the guide wire to the workhorse wire, then you can connect the robot. So it's actually kind of like a hybrid approach where you start manually and then you complete it with a robot. We actually published a paper about this in CCI. It was a 2-center experience from University of Washington and St. Luke's Kansas City Hospital. And when we looked into manual versus robotic assisted, CTO PCI, it was actually 48% of the procedure time, the operator could sit in the control room still, even after crossing. So we thought that's significant for the CTO operator because essentially you're not wearing lead and you're not getting any radiation during that procedure time.
So the main advantage will be based on the radiation exposure more than the contrast injection or others?
I think definitely the primary operator, the advantage to the operator is definitely there, and that's going to be less radiation and then less procedure time wearing the lead. But in addition to that, I think from the patient perspective, this is hard to prove, but we definitely can consider that we can put the stent precisely because the screen is right in front of you. When you're doing the exchanges, you don't have to worry about doing the exchange because the secondary operator is doing that for you with the robot. So you're just looking at the details about the previous films and then planning your procedure. And so those are kind of like the advantage of using the robotic system for the patients, but that's a little more harder to prove. Yeah.
All right, thank you.
Okay, I think that we must continue in English because Dr. Taishi have not good translation. Then please do the question in English. Who will do the next? Pedro, Alejandro, José, Juan, Alejandro. Your question, please.
Okay, thank you, Dr. Taishi. I have two technical questions. In the first case, you use a guideliner for support. The question is, you can handle the robot is capable to handle the guideliner, or the guideliner is handled by the assistant. And the second question is if the robotic system is capable to manage 2 wires, or it has a limitation to use only 1 wire and you cannot use the robotic system to perform a bifurcation PCI.
Thank you very much for the question, Dr. Fernández. So in terms of the guideliner, this is going to be inserted by the secondary operator at bedside because the robot doesn't have the capability of putting that in robotically. With regards to the 2-wire system, you have where's the resting port where you can put the guide wire that you're not using, but the robot only has 1 port where you can actually advance robotically. So if you're doing a bifurcation work, you can still do it by switching the guide wire, but you can only advance 1 guide wire at a time when you use the robot. We have done some DK cross techniques using the robot, but if you have to do that, especially if you're doing the kissing balloon inflation, you have to time it with a with the secondary operator, because the secondary operator has the control of the other balloon. The robot only has one port for the guide wire and one port for the balloon. And then the rest of it goes to the resting port.
Perfect. Thank you.
Pedro, can you give your question?
Hello, everybody. Dr. Hirai, thank you for the lecture. Actually, we have been using the CorPath system in our hospital for the last 1 year or so, and it's interesting because my feeling is that it's not gonna be the last generation that we'll have. This is the first generation that can actually enter into our daily practice. We can use it, but certainly it's gonna be something that will improve, and for sure, that's my feeling. It's gonna be part of the cath lab of the future. So my question to you is the following: do you think that if this happens, if the robotic PCI is going to be the next way of us doing PCIs, do you think that the training of the new physicians will need to be adapted to a new perspective, where they will be primarily trained in robotic PCI instead of manual PCI, or it's gonna be forever a manual procedure and robotic for some? So how is going to be the training for the new physicians, for the new fellows, in your vision?
Thank you, Dr. Thank you, Dr. Lemos. For the long-term future plan, I think the robot is going to be a very important aspect of PCI, and I think there's no question about that. In the near future, I think we still have to combine both in terms of the training. They have to know how to do manually, and they also have to know how to do it robotically. If you can do a good job with a manual PCI, the robotic PCI is not that difficult. It's just doing the same thing robotically instead of manually. So all our experienced operators in the panel, I don't think will have much difficulty. They'll do 5 cases and they'll know how to use it. So still, I think the training has to be both. As you mentioned, I think there's limitations to the robot. Main thing is that we can't use the over-the-wire system yet. And so definitely the technology has to improve. But if you have those technical advancement, then like you mentioned, I think there's no question that robotic PCI is going to probably become an important aspect of our PCI procedures.
Thank you,
José Álvarez.
Yes, thank you for the presentation. This is a new word for me. Thank you very much. Can you imagine aortic valve implantation with this robotic system, more precise implantation of TAVI?
I don't think the technology is there yet. I don't think that they can advance the large bore access. But I think in the future, if they can come up with the technology that accommodates that, I think that's a very interesting topic to explore. For sure. I think in some situations you can offer more precision with a robot. And so I think that's going to be very interesting.
Doctor Londero está.
Hugo, estás muteado.
Ahí está. Juan Mieres, ¿quieres hacer una pregunta?
Yes. Thank you for the invitation. Thank you for the lecture. Dr. Shai, do you think there are some limitation for the patients in the robotic procedure, or maybe in the future all the patient we can do from the robotic PCI?
Yes, so right now the main limitation is that we can't use the over-the-wire system. And so if you're doing the rotational atherectomy, if you're doing the CTO work, then you have to connect afterwards. And so right now I looked into how many cases we've done over the past 6 months, and it's about 30% of the PCI that I performed. So it's not for all cases, and you're still selecting the cases that you can use. But I think as you get better with the team and as the operator gets better, you can keep expanding. And so that's kind of the fun part with the robotic PCI.
Aníbal, tú tienes una segunda, Aníbal.
Yes, gracias, Hugo. Thanks, Dr. Hirai again. And I have a question for you and for Pedro, because Pedro is one of the very first operators in Latin America in robotic PCI, according to my knowledge. In the United States, which is the percentage of cath labs that are using this first generation of robotic PCI? And after you, I asked Pedro if this is the first cath lab in Brazil using robotic PCI. So please, Dr. Hirai, first.
Sure. The CorPath GRX is
low penetration right now.
Yeah, relatively low penetration right now. Yes.
Okay.
Yeah.
Pedro?
The robotic system, Aníbal, has just received regulatory approval for us to do it in routine cases. So it's I'm talking about 1 or 2 months ago. So Einstein is the first center. We started to do this as a research. Now we got Anvisa, which is our regulatory agency. We can do routine patients. There is one center that has already bought the robot, which is in Moinhos de Vento in Rio Grande do Sul, in the south. And there is another hospital that I'm aware of that is purchasing the robot. But, you know, the robot has CE mark, FDA approval, and in Japan too. So the penetration is low because I think it's new, and but it's increasing. If you see the numbers before and after the technology was bought by Siemens, it's increasing. You know, one of the things that I think is important to mention about the robot system is that when you think about the robot in surgery, you need special things to do surgery by robot. It's different from manual surgery. Now, it's not the case here in robotic PCI. You use the same balloons, the same guide wires, the same guiding catheters, the same stents and everything. So it's very easy to adapt the cath lab for the robot. Basically, you don't need anything. And price-wise, the price of the robot is the same of an IVUS. The console and the sterile part is the same of an IVUS. So it's very easy to adapt, very easy to get a robot in the cath lab.
Okay. Are there another questions, another comments? See, Gabriel.
So this is just for Dr. Hirai as well. I don't know if you have experience with the integration system for CTAs for guiding CTO PCIs. So I'm imagining in the future you doing your robot PCI also combined with this integration. So if you can tell us about a little bit on your experience, that would be fascinating.
Thank you very much for the question. I haven't used the integration software yet. We're going to start using next month, but I have used the CT scan for pre-procedure planning, and I find it very helpful when you're planning a case where the proximal cap is ambiguous. You can define where the proximal cap is, and then if you know that you're planning to do an ADR, you can re-enter where there's not much calcium. So definitely integration of the CT scan interests me as well. And I think if you combine that technology with the robotic system, that would be very, very interesting with what we can do in terms of, the guide wire skills and, trying to do some CTO work there as well. We do integrate the co-registration system with IVIS, and that's very helpful because we can measure the lesion length with that. The robot itself has a system where you can measure the lesion too. So there's a lot of ways to measure the lesion length. Yep.
Thank you very much.
Thank you.
Are there another question, another comment? Well, I think that we are on time. Then I have to say, Dr. Taishi, thank you very much. You made simple a complex matter. Then this is not easy. Thank you a lot for introduce us in a new world.
Thank you very much for having me.
Gracias a los panelistas, gracias a Siemens por darnos la oportunidad de ver este avance que, bueno, cuando yo comencé hace 60 años, no me imaginaba que iba a existir la angioplastía con balón. Recién empezaba la cirugía de revascularización. Y hoy, después de 55, 60 años, veo con extraordinario placer estos avances de la tecnología que nos están simplificando las cosas. Bueno, muchas gracias a todos por participar, gracias a Siemens por el patrocinio y nos veremos mañana en este congreso, exitoso congreso de SOLACI. Gracias al esfuerzo de los organizadores como José, Aníbal, Gabriel, etc. Buenas noches.
Buenas noches, gracias. Bye, good night.